Good morning, everybody. Thank you for being here. We wanted to start today with doing some introductions, if that's okay with all of you. It's really helpful for us to have kind of a general idea of who is in our audience each time. So can we start with Rhonda?
Hi, I'm Rhonda Navarro. I am a graduate special student. I'm looking to apply for the nurse practitioner acute care practice next semester. I'm a RN in San Diego right now.
Thank you, Rhonda.
Alan?
Hi, I'm Alan Fisk. I'm just here for technical support and to in case you need something.
Morning.
Becky?
Hi, my name is Becky Bailey. I'm with Nevada Rural Hospital Partners.
Dr. Johnson? 1 second, I'll take you off mute.
Come on.
Okay, go ahead, Dr. Johnson.
Dr. David Johnson, Healogics, Carson City.
Morning.
Good morning.
Morning.
Dr. Razak?
Yeah, my name is Dr. Razak. I am a medical graduate. I am licensed physician abroad, but right now I'm looking for medical residency here. So therefore I am joining your clinic. Thank you.
And Dr. Christensen? Go ahead, we can hear you. One second, Dr. Christensen, I'm going to take you off mute. All right, go ahead.
They got training downstairs, so I'm in my office.
That's Dr. Christensen, Ely. Dr. Kamyar?
Hey, Farzad Kamyar, manager Kamyar here.
Great. Tim O'Neill?
Hi, I'm Tim O'Neill. I'm a PA at Minden Family Medicine in Minden.
Great. Thanks for joining us. And Lori Skortzoff. Lori, are you there? We may not have audio for you. I'll follow up with you later. Yeah, I don't think we have audio.
Okay, well, good morning again. Thank you for being here with us today. Our whole team is here, which is very exciting. So today we're going to be talking about harm reduction, and we did not get any cases submitted for review today. So as we move through this little presentation, if you guys can just be thinking about patients that you may have questions about in relation to harm reduction or to really any MAC questions, please be thinking about that, because we'll have some time for that after the presentation. Okay. So it's, as I kind of mentioned before and during our last clinic, it's difficult for us to know sort of our audience and who knows what. So a lot of this stuff that we're going to be presenting today is really just the basics of harm reduction. So some of this might be a repeat for you, this might be new for you, and please feel free at any time to jump in and ask questions. So I wanted to, I put this picture of a bridge. I think it's a really kind of an important image to hold in your head when you're thinking about harm reduction, because a lot of what we do in treatment is we expect people to kind of jump from one side of the cliff to the other. We expect them to suddenly make all of these very dramatic changes in their life and let go of, the primary coping skill that they have or coping mechanism that they have, and we expect them to leave all of their friends and their playmates and playgrounds, and it's a really big thing that we ask patients to do. And so I like this idea of harm reduction as a bridge, is that we're giving them the steps and we're kind of guiding them across this process to get them from one side of the other in a way that is more realistic and more conducive for them to be able to be successful. So our goals for today, I guess I should introduce who I am for those of you who haven't been here before. And maybe our whole team, we should probably do that because we have new faces, so let's do that. So my name is Danica Pierce. I'm a licensed clinical social worker, and I work in the MAT program at Northern Nevada Hopes.
And I'm Jennifer Farfan. I'm a medical assistant at Northern Nevada Hopes. I work directly with the MAT program as well.
I'm Dr. Altasan. I'm a psychiatrist and a MAT provider.
I'm Carol Hain. I'm a physician's assistant and a MAT provider at Northern Nevada Hopes.
Mark Broadhead, addiction psychiatrist, VA Medical Center.
I'm Pete Ludlow. I'm the MAT nurse case manager at Northern Nevada Hopes.
I'm Crash. I'm the clinical ambulatory pharmacist at Hopes.
I'm Adriana, and I am a medical assistant, and I work for the Northern Nevada Hopes.
Thank you, guys. So for today's presentation, Jen and I are going to kind of take turns moving through these slides. So for today, our goals are to really kind of gain a better understanding of what is harm reduction. What is it and what is it not? Because I think there are a lot of misconceptions about what harm reduction is. And so we want to clarify some of those things. We're also going to spend a little bit of time reviewing the stages of change. So this is one of those things that I'm not certain everybody's necessarily familiar with. But if you are working with people who struggle with addiction, this is a very, very important concept to understand. Because it really should be guiding a lot of the decisions that we're making. So we're going to look at that and really look at why, making sure that we're assessing where that individual is really, like I said, driving the decisions that we're making and helping us set up patients for success. And then at the end, we'll open it up for questions or comments, and like I said, if you guys can just be thinking about cases or thinking about patients that you have questions around, it'd be really helpful for us to have a better discussion at the end.
So what harm reduction is defined as is to reduce harm stemming from health-related behaviors that are considered to put affected individuals and or their communities at risk for negative consequences. Also, these approaches are to seek and improve quality of life for affected individuals in their community, as well as it's more of an attitude rather than a fixed set of rules and regulations. So it's not something that we go, this is rule number 1, rule number 2. It's more of how we implement it in our community. Harm reduction.
Really quick, sorry. So really important to here, we'll talk about this a little bit more, is to think about quality of life. That's really what we're looking at. That's really the goal, is really to change the quality of life, improve quality of life, not only for the individual who's affected by addiction, but also the people around, the people in that person's life and in their surrounding community. It's really what we're looking to do. And it's important to stay focused on that being the goal, as opposed to some of the more traditional models around just abstinence and things like that.
So harm reduction as we know it. A lot of these things we do without even knowing that we're doing it. It's like putting on sunscreen to protect ourselves from the sun, using condoms to protect ourselves against sexually transmitted diseases, seatbelts, well, we all wear seatbelts hopefully when we're driving, bicycle helmets as well if you're riding a bike, having a designated driver when you're going to go out and you know that you're going to have a few drinks. Checking your blood alcohol levels to make sure it's safe to drive. Nicotine patches and gum, needle exchanges, also medication-assisted treatment program. Other things that I thought about were in school, we're teaching our kids about share, trying to help them learn to be abstinent. However, if they do end up having sex, what they can do to reduce the risk of getting any sexually transmitted diseases. Or another program that I thought about when I was growing up is DARE, knowing about drugs and awareness of that, knowing to say no. Are things that I thought about, but a lot of these things, like I said, are things that we don't even think that we're doing harm reduction, but we are.
Right. So as most of you I'm sure know, harm reduction is really sort of this global idea in public health. Obviously what we're going to be talking about today is medication-assisted treatment in relation to substance use disorders. But sometimes I think, especially as harm reduction sort of becomes more well-known in the substance use treatment world, there's a lot of stigma around substance use, and so there are a lot of ideas about harm reduction being enabling. And so it's really important to remember that harm reduction on more of a global scale, when we're talking about public health, these are all things that we do to keep ourselves safe. And using harm reduction in the treatment of substance use disorders is really, it's the same idea. It's really about reducing harm and improving quality of life. So I like how this was broken down, and if anybody's interested in the reference in the book that I used to pull a lot of this material from, I can get that to you. I really like how this is broken down into like these two ideals of having a compassionate stance with patients or with clients, but we're also using pragmatic strategies. So being able to really understand what are the high-risk behaviors and approach them in a way that's both respectful and inclusive of the individual. So we're really looking at meeting the patient where they are, and we'll talk a lot more about that later on, but being able to approach it in a way that is compassionate and non-judgmental. This is how we're going to keep clients and patients engaged. This is so important to understand that this is how we're going to keep clients. This is how they're going to get better, is by us presenting an environment for them where they feel that they're not being judged, where they feel connected, where they feel accepted, so that they can then engage in the services. So while we're doing that, at the same time, we're really looking at being pragmatic. What are the strategies that we're going to use? This is not a theory-driven model. This is based on what's reasonable, what makes sense, what is doable for the patient. So we're looking to reduce the harms of these behaviors through a lens of public health, looking at accurate, fact-based drug education to really make the best decisions for patients. So just really to kind of boil it down, I know we kind of already talked about this, but this is important that, we have to recognize that drug use and abuse and dependence is going to continue to happen. It's part of our world. We're human beings. There are a lot of reasons why humans engage in substance use and abuse. And while we're working on prevention, and while we're working on setting people up for success, and while we're working on how to limit these, limit the problems that substance abuse brings, we also have to accept that it is a reality. And so while we're doing that, we need to also understand that that substance use abuse and dependence is really complex. And there's a continuum of behaviors. So we've got people on one end who are completely abstinent or have, non-problematic substance use, occasional moderate substance use, to people who are in a full-blown addiction and who are unable to manage their lives in complete chaos. And so we need to recognize that our goal is to move people from that chaotic end of the continuum to a more reasonable, manageable level of use, whether that is complete abstinence or not, but moving people on that continuum.
Also, harm reduction establishes a criteria for successful interventions and policies as the quality of the individual and the community of life. So again, it's stressed around the quality of that individual and their life and the life of others, and well-being, but not necessarily cessation of all drug use. And it also calls for a non-judgmental and non-coercive environment to be able to provide services and resources to these people who do use drugs and the communities where they live in order to be able to assist reducing harm. So again, when they come to us to these certain programs, we have to make sure we're not being judgmental towards them, because they have to know that when they come to us, it's a safe place to where they could express themselves and let us know exactly what's happening, because that'll be the best way that we can help them. Also, it ensures that the individuals and communities are impacted by drug use, abuse, and dependence, and that they have a real voice, and the creation of these programs and policies designed to serve them, because again, we're not black and white. This is not what you do and this is where you're going to end up. A lot of these people are going to have like little tricks along the way, and we want to make sure that we are being open to that and know that they can come to us if they do end up having a slip. It also affirms the individuals and themselves as the primary agents of reducing the harm of their drug use, and it seeks to empower them and for them to share their information and to support one another in strategies that meet their actual needs. So again, with therapy, that helps them a lot to know that they can do this, and hopefully there's a light at the end of the tunnel, so to speak. It recognizes the realities of poverty, class, racism, social isolation, past traumas, sex-based discrimination, and other social inequalities that affect people's vulnerability and capacity to effectively deal with substance-related harm. And it also embraces and celebrates small incremental change, again, when they're meeting those little as that goal can be, whether they have a slip, how short that slip is going to be, if they end up getting housing if they were on the streets, being able to make it to their appointments on time, stuff like that.
Right. The incremental change, and if you think back to the idea of the bridge, right, is helping them take those steps to get from one side to the other and celebrating with them when they do have successes. And I know it sounds silly when we say, they get to their appointments on time, but quite honestly, sometimes that's a really big step for people to be able to organize themselves in a way that they can get to an appointment on time. And so it's easy to roll your eyes and say, how hard is that? But really for a lot of our folks, it's really not. And so when they are able to show up on time and when they are able to keep commitments and call when they're not going to make it, those are successes that we need to celebrate, because those are the things that help build the patient's, their self-efficacy and their ability to recognize that they are making changes. And so we need to help them with pointing those things out and celebrating with them so that they can stay engaged in treatment, continue to move towards a life that they desire that's better for them. So these are some of the things that I was talking about before. I think it's important to look at, because there's a lot of stigma around substance use, and there's a lot of stigma around harm reduction as it relates to substance use. So these are important. So harm reduction does not attempt to minimize or ignore the real and tragic harm and danger associated with illicit and illicit drug use, abuse, and dependence. So this is not, rainbows and butterflies. We're just gonna all be happy together and make this issue go away. That's not what this is. So we recognize that substance abuse dependence is dangerous, and people die. Lots of people die all the time. Causes all kinds of problems, physical, emotional, mental. It impacts communities. This is a very serious problem, and we don't ignore that. Oh, Siri thought I was talking to her. I don't know why, what I said. Harm reduction is not theory-driven. It's fundamentally pragmatic. I mentioned this before. So we're looking at what makes sense with this particular patient on this particular day. So we're taking them as they are on a given day, and we're looking at what is reasonable for this patient today. What goal can they accomplish today? How can we help them today? What do they need from us today? So we're looking at what makes sense, rather than just being driven by a set of theories or a set of rules and regulations. Which takes me to the next one, which is not. It is not an assigned set of rules, regulations, or policies. It can't be. We're working with a highly vulnerable, highly specialized population of people who have very unique issues. And so we have to take them as they are, case by case, and look at what makes sense for that person. And they need to be involved in that process, because us telling them what they need to do is not the same. It is an entirely different process when a client or a patient is involved in that process and they feel empowered to make decisions. They are much more likely to be successful in their recovery. Harm reduction does not threaten abstinence-based goals. There's a lot of people out there who think that this is just enabling people, that we're just letting them do, you know, what they think is best, and we're not pushing them into abstinence, which for a lot of people is really eventually where they need to be, because that's going to keep them the safest. But harm reduction is not in opposition to abstinence-based goals. You can still have both. You can have a patient, you know, moving them towards that as their goal is perfectly acceptable in the harm reduction model. And harm reduction does not mean that the client or patient is allowed to make all the decisions and or do whatever they want. So this does not mean that the patient is in total control of the treatment planning. That would not be safe, and that would not be appropriate for us as providers to allow that. So what we're looking to do is create a relationship with this patient or client where they feel empowered, and where we can support them. It's really about having a therapeutic relationship that feels safe for them, so that they can make decisions that work for them, that are also safe, and that we, you know, that we feel good about as well as providers. It should really be a cooperative collaboration in decision making. So the stages of change, again, I hope that everyone here is at least heard of this or somewhat familiar with this, especially if you are already working with people who struggle with addiction. This is really a very basic, important concept that really drives our ability to determine how ready an individual is for change. So if you're looking up at the top where it says pre-contemplation, that's really where a lot of, you know, this is where people are before they ever have any experience with treatment generally. Is they're in this period of pre-contemplation where they really don't have any intention of changing their behavior. They may not even necessarily be aware that there's a problem. Generally, this is earlier on in use. And so sometimes we get patients or clients into our practices who are in pre-contemplation because they're court-ordered. A lot of us work with mandated clients, and so this is a very difficult place to start. But this is where, you know, most people really begin before they really ever have any experience with treatment. And then what happens is generally there's some sort of situation or something, some shift where suddenly they're aware. They're aware that maybe there's a problem. So maybe their partner breaks up with them because, you know, they're having certain behaviors that are not tolerable. Or maybe they get arrested, or maybe, you know, they lose their job. There's some sort of consequence. Or maybe they just realize that they're tired all the time, or they're, not being able to perform at a level that they have previously performed at. So whatever it is, there's some kind of shift where all of a sudden there's some awareness that maybe there's a problem, but not necessarily a commitment to do it or to do anything about it. But oftentimes, especially with substance use, these consequences of use, consequences of behaviors related to use start to escalate. And this generally will push people into preparation. So people might start thinking about, well, maybe I should talk to somebody. Maybe I should see my doctor. Maybe I should, reach out to a friend. Whatever it is, there's a shift to where all of a sudden, okay, I'm thinking about maybe I need to do something. That's what we call preparation stage. And then moving into action stage. So there's some change. So they get up and they make an appointment with a doctor, or they go to an AA meeting with a friend, whatever it is. They've taken a step. So they're moving towards recovery. And then there's this period of maintenance where they're engaged in treatment or they're engaged in recovery. They're doing the things that they feel like they need to do to get their life back on track, whatever that looks like for them. And then there's relapse. And this is really important for people who aren't as familiar with addiction treatment. Is relapse is part of recovery. A relapse is not a failure. And if we label relapse as a failure, that will keep patients stuck. They will not get better if they are shamed or punished around relapse, because relapse is a part of the recovery process. And when I finish getting through this, I'll kind of help compare it to some other things that might be more familiar on a personal level for us. But relapse is part of recovery, because with each relapse, the patient has the opportunity to look at what happened. What happened? What was the trigger? What was it that, knocked me off track? And with each relapse, they gain more awareness around their own sort of process, their own triggers, the things that kind of get them a little bit squirrely. And the more that they know, the more self-awareness that they have, then they're able to prevent. And what we're looking for is not necessarily, if we expect the absence of relapse at the beginning, we're setting ourselves up for frustration and we're setting them up for failure. What we're looking for is more time in between relapse and shorter relapse. So we want them to be able to first recognize the signs of relapse. And then when they do relapse, we want to help move them to where they relapse and they get right back on track, rather than going and binging for 3 weeks, right? The next time we want them to have that binge be shorter and less intense. But so we're moving them through this process, the cycle of change. Every time there's a relapse, they don't necessarily go all the way back to pre-contemplation, of course, but sometimes they do, but not always. But with a relapse, they fall back into use. We get them back on track. We try to help them get back on track, and they move through this cycle. And it's really important to understand that this is a cycle, it's a process that happens with addiction. And again, to not set ourselves up for frustration by expecting something that isn't realistic. So just to kind of help understand, if everybody kind of listening can think about something in your own life that you recognize either in the past or currently as something that you want to change. And just think about, for a lot of us, it might be, oh, I really want to get healthy, or I really want to, have a better relationship with my child. Whatever it is, something in your life that you think about, that's something that you want to change. And just take a minute and look at the cycle of change and think about where you are. And think about moving through these steps. A lot of us might be in pre-contemplation, so we're not even aware, right? But something like getting healthy, right? So one day, I think everything's super great, and I have to walk up a flight of stairs, and I get to the top, and I'm like, oh my gosh, right? And I'm out of breath. Suddenly I've moved into contemplation because I'm aware. Like, I shouldn't be winded walking up one set of stairs. But maybe I don't do anything about it. Maybe I do. Maybe I continue to recognize man, I really am out of shape. This isn't good for me. And so then I think about, maybe I should go to the gym. So I'm moving into preparation. I'm moving into thinking about what could I do to get healthy. And then maybe I join a gym. Maybe I go to some kind of a yoga class, right? So I'm moving to these things. And maybe I commit to going to yoga 3 days a week. So I'm going to yoga 3 days a week. I'm working on maintenance, right? And then one day I decide it's too cold. I really don't want to get up and go to yoga today. And so I stop. We're in relapse. I've stopped the change process that I'm in, right? So at some point, maybe I decide to go back, and maybe I don't. This is just looking at how we move through these stages of change. So just think about that. If you're not familiar with this is a really important thing to just be thinking about in your own life. And we all have things that we need to or want to change in our life. And so looking at this stage and looking at how difficult it is to make change, and then thinking about these patients who we're working with who are in a full-blown addiction, right? Their brain chemistry is at play here. They're fully addicted. And so for us to expect for them to get from one side of the cliff to the other by just coming and seeing us and we say, okay, here's what you need to do. Here's what you need to do to make your life better. And we direct them. We tell them, you have to stop using. You have to do this. You have to do that. None of us in this room like being told what to do. And especially when it's something that, impacts our life in a very significant way. And then taking it a step further to something that's as challenging as the struggle of addiction. So just want you to kind of be thinking about that. So starting where the patient is. This is really about, we have to recognize that whether a patient comes to us, whether they're mandated, working with mandated patients, this is a little bit of a different ballgame, but we're really using the same process. But starting where the patient is. If a patient is coming to us for treatment, if they're seeking treatment on their own, we know that they're already out of pre-contemplation. They're already past, they're in that contemplation preparation phase of change. And so we have to really accept that, we have to accept their level of motivation, whatever it is, and whatever their goals are. We have to help them. So harm reduction is an umbrella, right? And when we're talking about medication-assisted treatment, we're talking about one piece of a treatment program, of a recovery program. It's just one piece. It is not the solution to a substance use disorder and addiction. It's simply a helper. It provides patients with stability. It provides them with some structure. It provides them with the opportunity to be able to engage in a recovery program. So starting where the patient is, meeting them where they are at, what it is that they need, it's really our responsibility to be able to engage them and to reach them. And we have to do that by being non-judgmental, by being compassionate, by understanding the stages of change, by understanding the incredible task, the incredible, I don't even know what the word is, this challenge of overcoming addiction. So it is our responsibility as providers to help set up an environment for patients where they feel welcome to come, where they feel welcome to be honest, because honesty is such an important, it's a key factor in recovery. If a patient or a client is not being honest, they're not practicing recovery. And so part of that onus is on us to create an environment where they feel safe to do that. So if a patient comes in and they relapse and we shame them and we punish them, they are not going to stay engaged in treatment. They're not going to be successful because they need to feel empowered and they need to feel like they can be honest and that they're making progress. This is why we celebrate those small incremental changes to move them through the process. So what we're looking at creating treatment goals that really focus on decreasing risk. And this is obviously what we're doing with medication-assisted treatment. We are replacing, when we're using buprenorphine, we are replacing we're giving them what their brain needs to help stabilize them so that they can do therapy, they can have an individual provider who they're working on the underlying issues that fuel addiction. They can go to groups, they can go to self-help meetings, and they can create a community of people that support them. They can go to work, they can maintain their responsibilities, because they have to be able to do all of these other things to get their life, to live a life that they're working towards. And so it really is the alliance between the providers, whether that's the prescribing provider. In our program, we're so lucky in our program to have such a multidisciplinary team. I know that's not available to all of our audience members today. Hopefully, as Matt and team-based care and patient-centered care becomes more widely accepted and available, we'll have more team-oriented approaches. We're so lucky because we have prescribing providers, we have a nurse, we have NAs, we have behavioral health that all work together. And it really is that therapeutic alliance between the patient and the providers that anchor them into treatment. If they don't feel welcome, if they don't feel accepted, if they don't feel like we're working together with them, they're not going to stay engaged. And so it's just really important to keep that in mind. So if you are out there prescribing and practicing and you're doing it on your own, first of all, thank you. But also, take that time. I know it's so hard because we're so busy and everything is chaotic all the time, especially if you're doing things on your own, but just so important to listen to what the patient is telling you. Patients will tell you what it is that they need from you if you just listen. And so really listening to hear and to understand, not listening to respond. I know this is basic stuff, but we're not listening just to hear what they say. We're listening to understand what it is that they need, what it is that they're asking for, and involving them in their own recovery process, because that is how they're going to be successful. I feel like I'm soapboxing right now. Okay, so any questions, comments, concerns, complaints? I always like to include complaints because you're totally allowed to do that. But yeah, and for anybody here, obviously our whole team is here, so.
Yes, I have a question.
Sure.
What is your success rate? I mean, what percentage of your addicted patients eventually don't relapse?
Are you asking specifically to our program at Hopes from our team?
Yes, for you actually specifically, because I know that you're involved in this.
Mm-hmm.
And so what is your success?
I don't know that we have that data today, but that's certainly something that we could gather up and we could get to you. I know for me, I'm just gonna speak anecdotally from a personal level, which isn't always super helpful, but that's all I have right now. I've been working in addiction for a while. I'm relatively new to Hopes. I've only been with Hopes for 1 year. And I've really only been fully engaged in our MAT program for about 6 months. I know for me, so I do individual therapy. That's what I do. So I'm meeting with the patient. So I'm doing a lot of sort of the other work separate from what the providers do, even though we're a team. So in our model, the patients are seen regularly by a prescribing provider, whether it's Dr. Altinson or Carol. And so they're getting their prescriptions, but what I'm doing is really all the underlying stuff. So looking at what are the underlying sort of the things that fuel the addiction fire, as I like to say. So we're looking at, interpersonal relationships, trauma, so much trauma. So I'm doing all of that work. And so what I have experienced in going from working with clients who have not been on medication-assisted treatment to clients who are, is they stay more engaged, they show up more often, and they work harder. They just have more structure and stability to be able to engage in therapy so that we can get work done. So historically, when I've had a full week caseload of individual therapy clients who are all struggling with addiction, my rates of people not showing up at all, just no-call, no-shows, is usually around 50%, which is very challenging. Half of them they just don't come because they, for whatever reason, they're actively high or they don't have transportation, or, whatever it is, they're a mess. So whereas now when, the vast majority of my clients are on medication-assisted treatment, my no-show rate is more like 10%, if that. Is much lower because they feel supported, because they have medication on board, and because we have a team approach. So it's not just me contacting them and keeping them engaged. It's our nurse keeping them engaged. It's our MAs keeping them engaged. And so they feel like people care and they feel like they have a place to go. And so for me, having patients who are on medication assisted or, are getting medication, I feel like they're far more engaged and they make progress faster.
I could answer a little bit of that as far as like the success rate. And you have to look at it in terms of where they're at in treatment. There are several people that have been with us that have moved on, and I don't know whether or not they've relapsed or not, but at the point that they left us, they were clean. And they were at least in the maintenance phase, and we had several of them, we had tapered them off of Suboxone, and we just haven't heard back from them. So I don't know all the numbers that have gone and whether or not they've relapsed or not. But out of our exact numbers, if we have about 50 active right now at Hopes, and I would think about 10 of them are like just getting started. They're just in the early stages in the first 3 months of getting clean. And then there's about 10 of them that are towards the end of their treatment where they're actually tapering off. And they're at different stages. Some of them are like 6 months into the program. Some of them are over a year. So if you look at success rate as when was the last time they relapsed, well, we have several people that haven't used in 5 years. And they've been on Suboxone in one form or another for a long time. And they haven't used for several years. We have some people that are on Vivitrol that have not used in the last couple of years. So they're still kind of in the maintenance phase, but they're progressing and they're moving on with their life. And just knowing that I have a handful of them that have gone several years without using, maybe 10 of them, that's pretty high. Because most programs, most people who are in this situation relapse continually. And you have to look at how long their sobriety was in between. And we're looking at their overall harm reduction levels. And if you're looking at their harm reduction, the success rate is extremely high. If you want to compare it to where they were before, it's very high.
Well, I think that, at the Hope Clinic, you guys are doing a wonderful service for these patients and the community in general. I agree that, somebody who stops being an addict for 10 years and then relapses, there can be a lot of harm reduction, and that's a worthy goal. I think that in general, addiction is one of the most difficult things to treat, and I applaud all of you who take it on. I also think that unless we know what our outcomes are, then it's going to be difficult to improve in the future without a baseline. And I know it's difficult to find out how we're doing because that requires a lot of resources. Do you guys have a plan to try to assess outcomes?
Yeah, we do. We talked about this in our first clinic. So this is new for probably a lot of you. That we're a pretty new program. We haven't, our MAP program really kind of grew organically just based on the need within our clinic. And so it's really only been in the last few months that we've really put a lot of structure in place. And we are doing a lot of data collection, but we're just in the very beginning stages. So we're set up for that. We're just not far enough along yet to really know. Just like I said, just anecdotally, but yeah, data-wise, we do have that in place.
I understand that. Okay, well, thank you, and thank you for the good work you do.
Yeah, thank you.
Yeah, and we actually do have some of this data. We just didn't have it with us, and I don't have the numbers, but we have a large spreadsheet. We keep track of all the patients that have been in the MAP program and where they're at. So I actually could get some of that information for you. Some of the things that I know off the top of my head, if we looked at our needle exchange program, which has been huge as far as like harm reduction principles go, we've had 73 people in the last year and a half transfer from the needle exchange program into the MAP program. So we've had 73 participants go from the needle exchange, actively using daily all the time, that have actually transferred into the MAP program. And there still are some of them that are actually still in the program. So that's a number there, and you think about the thousands and the thousands that are using, but we've been able to get 73 of them to go from the needle exchange into the MAP program, and that's where we break down those barriers. And so that's been really successful. But we are tracking a lot of this. I could put together some numbers for you, and I guess that would be interesting to see where they're all at.
Well, I think that, I'm not really particularly important in the whole scheme of things, but I would think that, with your harm reduction numbers and an ability to show some success, that might help improve funding at both the municipal, state, and federal levels, and getting some grants, and that might help to expand the success of the program. Just my 2 cents.
Yeah, and we do information for grants. You're right. Yeah.
I'm not the one writing the checks for the grants, so I'm not the one who's volunteering here. But thank you.
Did you want to say something?
Again, it kind of depends upon what you want to consider success. And if you want to consider success getting the needle out of the arm and getting their fingers out of your pocket, then if you were to look at, for instance, some of the methadone programs, which also use buprenorphine in the area, the number of folks, the reduction in IV drug use is incredible once you get them off of their short-acting opiates, so the ones that they're using intravenously. But more importantly, if you looked at, how do I know that they're not stealing? Well, in order to get take-homes, for instance, or in order to be able to be seen more frequently, this is true in the VA's buprenorphine clinic, you've got to kind of meet certain milestones. So you get seen weekly until you meet certain criteria, one of which is that you haven't gone to jail recently, or you don't have impending legal problems, or if you're employed. And in the methadone programs, for instance, their employment rate was 70%. 70% of the people going into those programs were employed. They didn't start there, but nobody comes in riding a hot streak. So most of these guys didn't have good jobs, fully employed, and their families back, but they eventually got there. So I think part of collecting our numbers is actually going to be dependent upon what numbers do we want to collect, where are our relative milestones, because from a strictly saving the public money point of view, just getting the needle out of the arm is your biggest cost savings right there.
I agree. Where I grew up, the police local police force were actually significant contributors to programs like this because they found that there was a substantive decrease in crime, especially assault and robbery, petty theft, and people vomiting on the street. So they provided funding and resources to a program similar in nature to this. There were many aspects that they looked at, and from a total police force budget, they were able to save some money.
That's awesome.
We've even had some patients that we've, if you want to look at harm reduction and them making changes in all aspects of their life, we've had some patients who have never had stable housing. For example, they would be considered chronically homeless. And just recently, we've had several of them who have now been able to be stable enough to the point where they've obtained their own housing and they're paying their own way. That's huge. That's huge. And there's little incremental changes there along with their use and their sobriety, which has continued to improve. But just the fact that they're in their own place and they're paying their own way, they're paying their bills, they're on paper, they're on the grid, not off the grid, that's a huge, huge improvement compared to where they were before. So there's a lot of areas that we could look at as far as like the success rate. Great question.
Yeah. Other questions?
I have a question. So how is your program specifically, like, is it referral based? Is it walk-in based? Because I'm from Reno. I do practice nursing in Reno still, and I see, on the acute care side, so many patients come in that we almost unwillingly forced to get sober because they come in, with another issue, pneumonia, infections, whatever, and then we send them into the streets with no resources. So I think, it's kind of, we're dropping a ball somewhere because, we have them for 7 days. Now you're clean, you didn't want to be, or you weren't ready to be, and now you're back into the, the community. So I was just wondering if it's like walk-in based, like where can we fuse a line of care almost, because I find it's frustrating on my end as a, acute care nurse.
It is. It's so frustrating. I think, we're in Reno, so we have a lot more resources than a lot of the other people who are present today who are out in the rurals. But even here in town in Reno, there are not enough services. There just aren't. We're constantly in this battle to try to fight to get people into inpatient programs that aren't necessarily appropriate for our level of care. There aren't enough therapy providers in town who take Medicaid, and it's such a challenge. So in our clinic, Pete, do you want to talk about that?
Yeah, how we do our referrals. One of our main sources of referrals come from Ridge House, which is a sober living program, and they have some inpatient therapeutic services. We have some direct referrals from Ridge House, and they have a transition program from prison or jail, and they transition to their program, and then they start to get treatment with us. Life Changes has some of those referrals as well. We have some agreements, some contracts with the courts, drug court, youth offenders court. They send direct referrals to us. Now, if we want to get referrals from the clinic, what we do tell people is that they need to establish with HOPES first, and then we can work them into the clinic through the internal referral process. Now, for you, you're a nurse practitioner. You practice where? Where were you at?
I'm not a nurse practitioner yet, but I'm a critical care nurse at St. Mary's in Reno.
Okay, so critical care nurse. So in your unit, a way for you to be able to refer somebody would be, they come in, you know that they're an addict, and you're getting their critical care needs stable. And before you discharge them, one of the great ways that we could have a connection here is contacting us and saying, hey, we have someone who wants to make changes. They are an addict. They've been using IV, or maybe they've been taking pills, and they're stable right now, but before we discharge them, we want to have a warm handoff. Is there a way that we could bridge this gap in getting them referred to you? And so making that phone call before they actually discharge. And then another way to bridge the gap would to be having one of the physicians discuss if somebody had a waiver, they can prescribe maybe buprenorphine for like 3 to 5 days for this person while they're preparing to get into hopes for that referral process, trying to keep them from maybe going back to falling off the grid again and going back to using, bridging that gap into their next handoff or their next appointment with us. That would be a great referral coming from a critical care unit. And that would be, you know, we just talked about this yesterday. We're actually going to be putting together some more information and brochures to be able to hand off to different facilities and hospitals so that people know how to connect with us and not just give them the number for hopes and have them call. Because you can get lost for a long time just trying to call and get in.
But yeah, we can, Rhonda, if you want, we can get you set up with our contact info. One thing I do want to say, Rhonda, is just because of the, you know, the work that you do, and like you were saying, you bring somebody in critical care, you treat them for pneumonia for a week, and then you're turning them loose. I don't know if you guys are already in practice of doing this, but if not, I would really encourage you to kind of spread this around. To make sure that you guys are really warning patients that if they are heroin users or, you know, heavy opiate users, and they've been essentially clean for a week because they've been in the hospital, that when they are discharged, if they go back to using at the level that they were using a week prior, they're at a really, really high risk of overdose and death. So I don't know if you guys are communicating that to patients, but if not, it might be really good to incorporate that, you know, as part of a discharge practice, to let them know that, like, if you are gonna go back to using, please be careful about the level, because it happens a lot where people are forced to get clean, whether in jail or in the hospital, and then they leave and they try to use what they have used, you know, before, and then they die.
Yeah.
Okay. Just something to think about.
Good point. And I think that gets missed off, you know, things like that we don't always have in the forefront of our mind because we have, you know, we're worried about 50 other things. But
Right.
I just find it like frustrating in this kind of practice that even, I mean, all kinds of substance use, alcohol, you know, we force these people to get clean basically with no resources. And I just think, you know, like your program says, like we have to get the patient where they want to be. And I think we need to care we drop that ball.
Mm-hmm. Yeah.
At the VA Medical Center, we can, if you refer to the alcohol and drug treatment program specifically for evaluation for buprenorphine, we can get them seen and induced within a week, in the same week, if they meet criteria. So, you know, we've actually got operators standing by. We still have, it is the VA, and so there are FedGov regulations, and so you got to make appointments, but usually, even if they walk into the emergency room, they can be seen by an ADTP evaluator within 48 hours.
Good to know. Thank you.
Start them on through buprenorphine level down.
One thing I just want to say that I had meant to say during the PowerPoint and I failed to do so, is for those providers out there who are working with these folks who are struggling with addiction, if you're not familiar with motivational interviewing, I would just really recommend that you at least read something about it and just have an idea of what it is. Motivational interviewing is really kind of the primary go-to technique when you're talking about harm reduction, because it's the most engaging way to kind of get clients hooked into treatment, because it really helps them. It's really about helping the client become more aware of that cognitive dissonance around their use, and sort of get them engaged and motivated into treatment. And it's very, very simple. It's simple things, the way that you ask questions, just kind of the way that you think about the information you're trying to get. I think if you're not familiar with it, just getting some of the basics of, you know, rolling with resistance, and, you know, just, I think it's so simple, and it does such incredible, it changes the dynamic so easily in such a powerful way, that I think everyone who's treating addiction should be familiar with it. Just throwing that out there. In all your spare time, you know.
Do we have any other questions for the team? I do have everyone on mute, so to unmute yourself, please use the microphone icon in the lower left corner of the Zoom screen, or if you're joined by phone, it's *6. Go ahead, Tim, we can hear you. Tim, do you have a question?
I would also just like to say, if for those of you who come regularly, or whether even if this is your first time, if you feel like you might want to join this clinic again, please don't hesitate to let us know what would be helpful for you. I know I kind of probably sound like a broken record, but it's really kind of a challenge for us to plan these presentations, because we don't necessarily know what you guys know and what you want. So please, if there's something that you're struggling around in your practice with Matt, or if you're not practicing Matt yet, you know, what the barriers are, you know, please let us know, because we really want this to be valuable for you guys. And, you know, we know that you all are very busy, and so we want to provide you with what is helpful for you. So please don't hesitate to give us that feedback on what you'd like to see from us, and what's working well and what's not working well. That's helpful for us to know too. So please do that if you feel okay doing that.
Any other questions before we finish up?
So next time, our clinic next time, do you guys want to, either of you want to just give a little spiel about our next clinic?
Yeah.
Do a commercial?
Yes, a
Sell
commercial.
it.
Sell it hard. I'm Crash and Carol here. So next time, you know, really we're just going to be looking at buprenorphine and naltrexone, and really going over pharmacology and some very basic things, drug interactions, receptors, and so forth. There's later discussions where we'll get more into induction and then maintenance and then titrating off. But obviously, you know, some of that can overlap. And some of the history, too, of buprenorphine, which is very interesting, because you always kind of wonder, like, how did we get what we have today, and packaged certain ways? Why is it just one company makes it, and so forth? So, an interesting backstory.
Yeah, just the nuts and bolts.
The nuts and bolts.
The medication, how it evolved, because I think we all have it's also interesting how the opioids have come up through history and at the point where we are now. But I think it's now the shift is, the focus is on what we can do with the new medications, or they're not really new, to help with treatment.
It's gonna be amazing.
And that will be on Wednesday, November 8th, starting at 8 a.m. again.
All right, thank you so much, everybody. Have a great day.